So today we're going to do the dissection of the superficial back. So as we begin, we'll just make some marks to follow for doing the skin incisions. We're going to start about the external occipital protuberance, and we're going to do a midline cut down to about the level of L5 here. And then we're going to do some transverse cuts in order to create some skin flaps that we'll lay laterally. We'll do one incision that'll be laterally here about the level of L5. We'll do another one that just at the inferior border of the scapula, and then we'll take another incision and go from the root of the neck across the point of the shoulder here, and that will allow us to reflect the skin back and access those muscles that we want to see. So oftentimes when you're getting ready to do your dissection, it's a good idea to fill for some of your bony landmarks. So you find your external occipital protuberance, you come down. On some of these, the skin gets quite thick and hard, and so it's hard to fill a lot of the bony landmarks through here, depending on how the cadaver's been laid. But we'll go ahead and make some of our marks as we're going midline here. And we want to stay above the iliac crest, and so we'll make those marks here laterally. Find the inferior border of the scapula and come just inferior to that, about an inch or so. And then another right through here. So start up at the root of the neck, and we're going to work our way toward the point of the shoulder here. You can also do another flap here in the neck. So you can go just transversely from the external occipital protuberance about to the mastoid process. So you can do another flap there. We'll leave that one intact so that we can later do a head and neck dissection. So now you'll start with your incisions and making sure to start superficial. If you need to take it a little bit deeper, you're always welcome to do that. But once you've made that cut, you can't uncut it. So we start a little bit superficial. Another thing to be aware of is on these cadavers, oftentimes the skin in the back is quite thick. So you have a thicker layer of epidermis and dermis. All right, another thing I failed to mention is oftentimes when we get these cadavers and they're in the supine position faced up, they're laying on their back, and so they can get quite rigid. So one thing you might want to do as you're doing the dissection of superficial back, dissection of the posterior shoulder and arm, is get a block. We have some plastic blocks that you can put under the anterior surface of the body to try and flatten that out so you can gain access to these regions. Now once you've done your incisions, you want to grab a corner of the skin at one of those little flaps that you've created with your hemostat, and then start to retract it back from there. So here you can see we're starting to get into that superficial fascia, which is largely adipose. You'll have variable amounts of that superficial fascia depending on the body and also depending on the region. So that's that yellowish fatty tissue that you're seeing right there. Just on this surface, you can start to see some of the dermal tissue, which is the deep surface of the skin. As you're doing your dissection, especially if you're working in groups, it's kind of nice to have a partner that's helping you, especially as you start to reflect more of the skin back. Now, one thing you want to make sure is that their hands aren't in the way, so if they have some hemostat or something, rather than just their fingers, that'd give them a little bit more security that you're not going to cut their finger off. Yeah, that'd be great. Yeah, if you want, you can grab right there and reflect that back. Now you can start to see and appreciate a little bit that deep surface of the dermis if you're removing that and keeping in place the superficial fascia has kind of an orange pill appearance to it. So that's the appearance of the deep surface of the dermis. I'm keeping intact the superficial fascia so that you can get a good view of that and appreciate the layers as we're going from superficial to deep. Notice Logan's starting to get a little bit skittish as my blade's coming closer to his finger. If you don't trust your partner, that's where you could grab a hemostat and make sure that you're out of the way.
Tell him how you're working your scalpel.
So another thing that's helpful to make sure that you're not going too deep is instead of orienting your scalpel deep, you keep it superficial, and then you kind of feather or splay along up toward the skin, and that helps to separate that superficial fascia from the deep surface of the dermis, and also ensures that you're not going too deep and destroying some anatomy that we want to preserve. An important part of this also is just making sure you keep tension on the skin. As you have tension, then that's doing a lot of the work for you, so you don't have to cut quite as much. All right, we'll continue on as we go down the posterior side of the back here. You'll notice this right here is all superficial fascia. It's largely adipose fatty tissue with some loose connective tissue in there. So after we reflect the skin here, we'll also come back and remove some of the superficial fascia so that we can see the deep fascia and then get into the muscular tissue. Now, as you're doing your dissection, you want to make sure that this isn't the time that you're figuring out what's there. This isn't a treasure hunt or a discovery process. You should know the structures you're hunting for and where you're going to find them. So make sure that you do a review of the relevant anatomy prior to starting your dissection. Now, one of the things you'll notice that we can't see here is we have cutaneous nerves that come through. They'll penetrate the trapezius and latissimus dorsi that are going to be underlying this, and they'll come up to innervate the skin. We don't preserve those intact, but as we remove the superficial fascia here and get down to those muscles, hopefully we'll be able to see some of those ligaments piercing the latissimus dorsi and the trapezius as they were headed toward the skin. Now those nerves, they're coming off of dorsal rami, but they don't supply the muscles of the superficial back. The muscles of the superficial back are actually supplied by ventral rami, and we'll talk about those as we get to them. So that's pretty good for reflecting the skin. We'll go ahead and clean up just a little bit of those juices with some paper towel here. You know, try and keep your work area just as clean and as dry as you can. Now there's different techniques for removing some of the superficial fascia. Brother Palmer showed you a technique using the back of your scalpel where you can kind of liquefy some of this fascia. Now you'll notice through the upper back here, it's pretty thick, even through here. Once we get down to the lumbar spine, right midline, it often thins out, and here is where you run into thoracolumbar fascia that we'll see. It's a deep fascia that lots of the latissimus dorsi will insert into. Through here, still quite a lot of superficial fascia that we'll need to remove. You just have to take care that you're not getting into the underlying muscle fibers. You can see we're just starting to pick up some of those muscle fibers here, and so we want to maintain those intact. You want to make sure that as you're removing any tissue, you keep it in the appropriate bin, because we'll collect that and when we're finished with our dissections, we'll actually take it back with the cadavers to be cremated. Once you get here, you can also start with some of your blunt dissection using your fingers or a blunt probe. A lot of the connective tissue is actually quite thin and fragile, so you can get through that without even using your scalpel. On a large area like the back, when you're working in your group, it would be easy for one or two of you to work in one region, down toward the lumbar spine, another group to work a little bit higher up toward the upper back and thoracic region as you're removing some of this fascia, because this can be quite time-consuming and tedious to do. So Logan's demonstrating that technique of liquefying some of that fat using a blunt edge here. As you remember the dimensions of the trapezius, we're starting to expose fibers of the trapezius up here, and Logan's exposing some of the fibers of the latissimus dorsi. Now the trapezius is going to start high, inserting from the neck on the lateral third of the clavicle, the acromion process of the spine of the scapula, and then it's going to slope inwardly toward the spinous processes here. And so we can start to delineate and make out some of those muscle fibers here. So it's important that you find those and make sure that you're not cutting through those muscle fibers as you try to expose them. All right, so last time we had removed the skin, the superficial fascia. Since then, we also removed some of the deeper fascia to really expose these muscles. So we have the latissimus dorsi right here, nice broad triangular shaped muscle. Up above it we have the trapezius. And so what we have to do now is reflect these muscles in order to see some of the deeper muscles below. So we'll start by reflecting the trapezius. We'll start from the inferior border, which is another thing to mention about the trapezius. We have these three different heads or fibers that are oriented a little bit differently. Toward the inferior portion here, we have the inferior border of the trapezius, and notice its fibers are angled downward. Right through here, we have the middle trapezius, and its fibers are oriented transversely. And then up here is what most people think of as the traps, the trapezius. We have the upper trapezius, and these fibers are going to angle a little bit more superiorly. So we're going to reflect this back, careful not to destroy the underlying tissue, and also to make sure we preserve the neurovascular bundle. So the accessory nerve, cranial nerve number 11, is what will innervate the trapezius muscle. And then we also have a branch off, typically the transverse cervical artery that supplies it as well. So I already just started this. Now we'll do your cut just lateral to the attachment point on the spinous processes. So we've cut up a little ways. We'll continue this up superiorly. Again, careful to avoid destroying the muscle that's deep to it. We also have to release it from the spine of the scapula here so that we can reflect it well. Now you can see here we've started to reveal that neurovascular bundle. So again, that's the accessory nerve, cranial nerve number 11, as well as a superficial branch off the transverse cervical artery that comes here on the deep surface and supplies the trapezius here. I'm just using a blunt probe right now to separate some of the deep fascia, the fascia that's surrounding the trapezius, from the fascia that is investing these muscles just deep to it, which right here we will expose the rhomboids, the rhomboid major and the rhomboid minor, as well as the levator scapulae. Now, in order to finish reflecting the trapezius, we will have to sacrifice the neurovascular bundle right here. I'll preserve them as they attach and insert into the trapezius, but we'll release them here as they're going through the rhomboids, and that will then allow us to continue to reflect the trapezius here. Again, being very careful that you don't go too deep and start to cut into the rhomboideus muscles. So we've reflected back the trapezius, maintained the neurovascular bundle as it penetrates the trapezius, but we had to cut it as it penetrated the rhomboideus in order to allow us to reflect the trapezius all the way back. Now that we've reflected the trapezius, we started to expose those underlying muscles. Right here, attaching from the medial border of the scapula onto the spine, we have two muscles, and it looks like their fibers are all connected, but we've got our rhomboideus major, and then we have our rhomboideus minor, or rhomboid major and minor. Rhomboid minor, its attachment points are lower cervical, upper thoracic, so we're looking at C7, T1, and then the rhomboid major is attaching further down, both coming onto the medial border of the scapula and really accomplishing the same job. So their fibers look like they're really all merging, which they kind of are. Also, we're starting to pick up a little bit of another muscle right here, which is the levator scapulae. And the levator scapulae originates off the transverse processes up in the upper cervical spine and then inserts down here onto the superior medial border of the scapula. So again, just doing a little bit of blunt dissecting using the probe in order to separate some of the fascia. And here's kind of our separation for the rhomboid major and minor. A little bit of fascia that goes there. Again, rhomboid major, rhomboid minor, and then just the beginning of the levator scapulae down here. So we can clean this up a little bit more. We can remove some of the deep fascia to expose these muscle fibers. But the next thing that we're going to do is we're going to reflect back the latissimus dorsi in order to reveal the muscles that are deep to it. So on the latissimus dorsi, again, we want to be just lateral to its insertion points here, and we'll preserve some of this thoracolumbar fascia that inserts down here, and then we'll reflect it laterally. Again, being careful to preserve its neurovascular bundle as well. You want to be particularly careful here because deep to this we have the serratus posterior inferior, which is a very thin muscle, and so if you go very deep it would be very easy to cut right through it. So you notice the cut, we're starting to fan out, again staying lateral to the attachment points for latissimus dorsi and preserving the thoracolumbar fascia. So I'm leaving just a little bit of the latissimus dorsi here as its attachment site. And down here we start to get very, very thin. Yep. As I'm dissecting here, I'm still using that blunt probe, just breaking through some of this fascia and now reflecting back the trapezius, or the latissimus dorsi, excuse me. We already did the trapezius. Now by doing that, it also highlights another muscle that is kind of latissimus dorsi's best friend. It's the helper muscle, latissimus dorsi, and shares in the common action, which is primarily extension and adduction, adduction of the humerus. So this right here is that teres major muscle. And as we're removing some of the fascia down here, we start to see another muscle that we'll also see from the anterior aspect, but we're starting to see part of the serratus anterior muscle, which originates on the medial border of the scapula and then wraps around and attaches to the ribs. One of its primary functions is for stabilization of the scapula throughout a range of motion, but also helps with, we call it scapulothoracic movement. And so as it contracts, it'll help with a little bit of upward rotation of the scapula, which then facilitates complete adduction to 180 degrees, so raising the arm above your head. Now that we've reflected back the latissimus dorsi, you see some of those very, very thin muscles that I was referring to earlier. These are the serratus posterior inferior muscles that attach onto the ribs, influential with respiration, not as a primary mover for respiration, but partially due to proprioception, their ability to detect movement of the thoracic cage. We also, in addition to this serratus posterior inferior, we have a serratus posterior superior, but you can't make out the margins of the muscle fiber to any great degree because they underlie the rhomboideus. So we'd also have to reflect back the rhomboideus major and minor muscle, but we can start to pick up some of their fibers right down here. So now we will reflect the rhomboid major and the rhomboid minor so that we can see the serratus posterior superior. Now once we've done that, that's gotten us through the superficial back muscles. Now all these muscles that we've talked about so far, they're referred to as superficial back muscles because we find them on the back, but they're not part of the true back muscles because they don't act on the back. These muscles are largely acting on the upper extremity. All right. So now that we've removed the rhomboideus major and the rhomboideus minor, we can get a little bit of space between the scapula and then the ribs here. And you can see the margins of the serratus posterior superior as they run here underlying or deep to the rhomboids. So that takes us through the superficial back. The next dissection we'll do here will be of the deep back muscles that we can now start to see. So we'll talk more about those in an upcoming video. One other muscle is probably good to mention right here. Although it's part of what we call the rotator cuff muscle, and we can see margins of the rotator cuff here as well, which we'll cover when we talk about the posterior arm and shoulder. On the anterior surface of the scapula, which is right here where my hand is the fourth muscle of the rotator cuff called the subscapularis. There's three other muscles that we can see some of their margins. We have the supraspinatus muscle right here that's in the supraspinous fossa. Again, that we expose as we reflected back the trapezius. We have right here in the infraspinous fossa, the infraspinatus muscle. You can't see many of the muscle fibers because we need to remove that deep fascia. And then right down here, we have another muscle that's the teres minor that is also part of that rotator cuff. And then on the anterior surface of the scapula, the subscapular fossa, the subscapularis muscle. All right, so after revealing or making our skin flaps and then doing the superficial dissection on the left back, we decided to make those same skin flaps and start to reveal the muscles on the right side of the superficial back. So I made those incisions. We removed the superficial fascia and started to remove the deep fascia, and we came across something that was quite interesting. Now, in anatomy, we have something that we call anatomical variation, which means that no two bodies are exactly the same, particularly when it comes to some of the nerves, the blood vessels, the veins, especially the smaller, more obscure ones. You can get a little variation. Typically, though, in terms of the musculature, it's pretty standard from one body to another, and particularly from one side of the body to the other. Remember, we have the latissimus dorsi right here. We reflected the trapezius, the latissimus dorsi on the left. As we were doing the dissection on the right side and removing the deep fascia, we noticed something interesting. And I don't know if it's apparent to you right off the bat, but the right side does not have a latissimus dorsi. We looked through the fibers and the subcutaneous tissue. We searched to see if we could find any remnants of those muscle fibers, because sometimes if there has been a case of nerve damage, you start to get atrophy of the muscles start to wither away and they shrink up, but you'd still find their muscle fibers. Or occasionally with things like polio, or when there's atrophy, you start to get these fatty infiltrates. So the muscle fibers atrophy, they'll kind of go away, and then you get the fat that kind of invades and would take up the place where that muscle belly used to be. In this case, there's just no remnant, no sign whatsoever of the latissimus dorsi. So on the left, we had the latissimus dorsi, and as we reflected that, we found the serratus posterior inferior. On the right side, when we reflected the skin flaps, there was no latissimus dorsi, and so we immediately saw the fibers of the serratus posterior inferior here. It was interesting to us. We'd never seen anything like that before, and so we did a little literature search. There's a condition that we found where occasionally you'll have hypoplastic or small muscles. Usually it's accompanied with other symptoms and other specific variabilities, but typically not total absence of the latissimus dorsi. In this case, no latissimus dorsi whatsoever. We did find one case back that was published in 2012, and there was a lady that had cancer and subsequent radiation therapy. Later on, she developed a shoulder sarcoma, and as they went in to do the surgery to remove the sarcoma, they were looking for latissimus dorsi because its fibers, because it's such a big, broad muscle, it works well to use latissimus dorsi in reconstruction, but they could not find the latissimus dorsi on her at all. When they went back and reviewed the CT scan they had performed, they realized that it showed that there was absence of the latissimus dorsi. They just didn't know at the time because they were not looking for it. To our knowledge, this is one of two cases of absent latissimus dorsi. Now, remember, we talked about previously how there's another muscle that helps out with that, the teres major muscle. Now, on this right side, the teres major muscle is quite substantial, and so the teres major muscle could have been taking up a lot of the slack from what the latissimus dorsi would have done. But even at that, there, we suspect would have been some noticeable signs of having that absent latissimus dorsi. Besides that, there's no other real variance in the shoulder girdle, the muscles as revealed so far. So very puzzling to us and quite interesting.